Okay, so good evening, everyone. My name is Bex Parker, and I'm the Communications Officer for the Wolfson Centre for Young People's Mental Health. We're thrilled to have you with us this evening for the first of many Wolfson Centre webinars. I'm really pleased to be joined this evening by three of our wonderful researchers from the Wolfson Centre, Dr. Chris Eaton, Dr. Vicky Powell, and Dr. Yulia Shenderovich, who will each be presenting a 50-minute talk as part of our Youth Mental Health Day webinar. For those of you who may not know, the Wolfson Centre is a brand new research centre that opened at Cardiff University in October of last year. And it's the first centre of its kind in the UK, focused on undertaking research to improve young people's mental health, particularly for youngsters living with anxiety and depression. So before I hand over to our first speaker, just a few little things for housekeeping from me. So as I said, each talk will be about 15 minutes in length and then followed by a short Q&A session. Please make use of the Q&A box. I'll be monitoring that throughout the webinar. And if you've got any questions for any of our presenters, please pop them in there and I know they'll try their best to answer them. And the session will also be recorded and uploaded to the Wolfson Centre YouTube channel after the webinar's finished. So you can always check back and watch it again should you wish to. So before I hand over to the first speaker, I'm going to put a few questions to our audience using Mentimeter. So this is a participation tool that helps us gauge who's in the audience tonight and what you're hoping to learn from this evening's webinar. So if you could all head to www.menti.com, the link for which is now in the chat, along with the unique code that should give you access to my presentation. Participation isn't compulsory here, but it is really, really useful for us just to see who's joining us on this very warm September evening. So I will share my screen and we will get started. So hopefully everyone can see that. So just wait a few moments for everybody to head to menti.com and use the unique code, which is 27160325. And the first question I'd like to put to you all this evening is, how would you describe your primary role in relation to young people's mental health? Are you a parent, carer, researcher, practitioner, or an expert by lived experience? And fantastic. It's always a relief when the answers start arriving. Thank you. Just give everyone a few moments to catch up here. That's great. Lovely. So it seems like we've got a real mixture of more people. Thank you. Okay, that's fab. Thank you. My next question is, what are you hoping to get out of today's webinar? Are you hoping to learn something new, find out more about mental health research, or ask our researchers a question on their area of expertise? So a little bit of a more long answer possibly here. So I'll give everyone a few moments to have a think on that one. Oh, that's great. So it seems lots of people are keen to find out more about the research and the plans at the Wolfson Centre. That's fab. Thank you very much, everyone. Really, really useful. Thank you. So I will be back again at the end with a final question for you using Mentimeter again. But for now, I will stop sharing my screen and introduce our first speaker this evening, who is Dr. Chris Eaton. So Chris is a research associate at the Wolfson Centre, having joined the team in March of this year. And Chris's role sees him working across the centre and with Welsh Government to ensure that the centre's research work will effectively inform and help evaluate Welsh Government youth mental health policy. Chris, I'll hand over to you.
Well, thanks very much, Bex. I'll just share my screen. Okay, so I hope you can all see my slides. Great, so thanks very much for the opportunity to present this evening. As Bex said, I'm Chris Eaton and I'm a research associate in the Wolfson Centre for Young People's Mental Health here at Cardiff University. And in this talk, I'll be discussing how Wolfson can work with Welsh Government to inform and evaluate national policy for youth mental health here in Wales, and why the Wolfson Centre is well placed to do this. So just a brief overview then. I'll start with an overview of the Wolfson Centre for Young People's Mental Health, and then I'll talk about why it's important for researchers to liaise with policymakers if they aim for their research to lead to policy changes. I'll then discuss how and why the Wolfson Centre is uniquely placed to be able to inform and evaluate policy for youth mental health, and finish with a summary of the key points of the talk. So starting then with a very brief overview of the centre. As Bex mentioned, we're a new interdisciplinary research centre focusing on reducing anxiety and depression in young people, co-directed by Professor Stefan Collishaw and Professor Fran Rice. And we want to work with Welsh Government to conduct research that is relevant to their policy priorities, and which in turn can contribute to informing and evaluating youth mental health policy here in Wales. Okay, so if we want to conduct research that can help inform policy, why is it important to develop links with policymakers? Well, whilst robust research findings are very important in the policymaking process, there are other considerations for policymakers, such as the economic costs associated with implementing a policy, the effects on social, cultural, economic and environmental well-being, and how the policy fits in with the current programme for government. If we want our research to rapidly inform policy and practice in youth mental health, we need to ensure our research considers key policy questions or priorities, that it has the capacity to evaluate current policies, and that any research findings and policy implications are clear and accessible to policymakers. So I'll now move on to discuss the expertise and resources the Wolfson Centre for Young People's Mental Health can access that makes it well placed to be able to conduct research which can inform and evaluate youth mental health policy in Wales. So the first point to discuss is the multidisciplinary expertise of the Wolfson Centre. We bring together academic and clinical experts in various aspects of youth mental health, and this is reflected in the structure of our 5 research work streams. The first work stream will seek to identify risk and protective factors for depression and anxiety using large-scale, longitudinal data. The second aims to identify the genetic and environmental factors that could contribute to anxiety and depression, and to explore whether we can separate and classify different types of depression based on genetic risk factors. The third work stream explores new interventions to support young people and families where a parent suffers from depression. The fourth will look at the role schools play in promoting positive mental health in young people. And the fifth will use population data uniquely available in Wales to better understand the long-term outcomes of young people who experience anxiety and depression. And all of this research will be guided by international scientific experts in mental health research via our Scientific Advisory Board. And we'll also liaise with clinicians, schools, the NHS and Welsh Government on our research aims and the best way to implement research in policy and practice via our Implementation and Engagement Board. Importantly, we'll also seek feedback about our research questions, methods and findings from young people with lived mental health experience themselves in our youth advisory groups. So we can see then that our centre has a strong general infrastructure that will allow us to conduct policy relevant research that could have a direct impact on the lives of young people with mental health difficulties. I'll now move on to talk about some examples of some more specific resources we have access to that allow us to work with Welsh Government to inform and evaluate policy. So the first example then relates to the evaluation of Welsh Government mental health policy in schools. Over the last 10 years, the Welsh Government has pursued a strategy known as the Together for Mental Health, with the broad aims of improving mental health awareness, building resilience, and improving the accessibility of support for people with mental health difficulties. A focus has been given to schools, with school counselling services having been introduced by the Welsh Government over the last few years. And moving forward, Welsh Government will be implementing the whole school approach to emotional and mental well-being, whereby schools act as hubs for improving mental health awareness, for building resilience, and can act as a first line of support for those experiencing emotional difficulties. So how then can we evaluate the impact that this policy will have on young people's mental health? Well, one of our research work streams in Wolfson focuses on understanding mental health in schools, and this is led by Professor Simon Murphy and Professor Graham Moore. This work stream will use the Schools Health Research Network, or SHRN for short, which is a partnership between the Decipher Centre, Welsh Government, Public Health Wales, and Cancer Research UK. 210 secondary and middle schools in Wales are involved with the network, and every 2 years, SHRN surveys pupils in these schools. Since 2019, this survey has included validated measures for mental health, and in the 2019-2020 survey, around 120,000 young people took part. In addition, schools themselves are surveyed about their environment, policies, and practice. We can see then that this is a hugely important resource and provides the framework for understanding how a change in school mental health policy, such as the whole school approach, may be associated with a change in pupil mental health over both the short and the long term. And more broadly, the timing of the SHRN surveys, with one being in 2019 and another one happening again at the end of this year, means we will soon have measures of pupil mental health before and after the onset of the COVID pandemic, allowing an understanding of the ongoing and longer term impacts of the pandemic on pupil mental health and supporting the planning of appropriate COVID recovery strategies. But what about assessing mental health outcomes beyond the school years? Well, uniquely in the United Kingdom, Wales has access to anonymised national data sets on clinical outcomes covering the vast majority of the population. For example, data sets on GP diagnoses or emergency department attendances. These data sets are collated and can be anonymously linked together in the Adolescent Mental Health Data Platform and via the secure anonymised information linkage data bank. Professor Anne John leads the Wolfson workstream, which focuses on using these resources to explore the onset, course, and outcomes for people with depression and anxiety. And with participant consent, the SHRN data that I mentioned earlier can be linked to SAIL records, allowing us to explore the impact of national changes in youth mental health policy on young people's well-being beyond the school years. And something else to highlight about these resources is that in the Wolfson Centre, we're interested in testing interventions to help reduce depression and anxiety. For example, earlier I mentioned Professor Fran Rice leads a work stream developing and testing interventions to prevent depression in adolescents who have a parent who is experiencing depression. In mental health intervention studies like these, participants may drop out and it's costly to follow them up over a long period of time. Again, with participants' consent, we have the capacity to link participants' data from intervention studies such as these to their clinical records in SAIL. And so in this way, SAIL can support efficient, low-cost follow-up in intervention studies over a long period of time. And something else to highlight is that the Wolfson Centre has created a linked research post with Welsh Government to help support research policy relationships, and that's the role that I'm in. So to help ensure our research can inform policy, I'll be working with researchers in the Wolfson Centre and with colleagues in Welsh Government to ensure researchers liaise with policymakers throughout the cycle of a research study. Currently, we're looking to set up regular meetings with the research leads from Wolfson and the mental health policy leads from Welsh Government so that they can set out their policy interests and key questions, and we as researchers can advise how we can potentially address these. And to ensure our research findings are accessible to policymakers, we'll aim to disseminate our findings across multiple channels, including in publications that don't have paywall restrictions, on social media, and in briefings to policymakers. We'll also aim to make sure any policy implications of our findings are clearly stated in research publications. And finally, in addition to helping with the ongoing research of the Centre, I'll be looking to work with colleagues in Wolfson and Welsh Government to co-design new pieces of research. For example, we're currently considering a study which explores the views of young people on the Together for Mental Health strategy to help inform the next iteration of this strategy. So when ensuring our research is policy relevant and can lead to rapid change to the lives of young people, another very important consideration we need to consider is the view of young people themselves. And I mentioned earlier about how we discuss our research questions and findings with young people in youth advisory groups. So just to go into a bit more detail about this, we're currently looking for young people aged 14 to 25 with lived mental health experience to take part in our youth advisory group. They'll help us to identify key questions of relevance to them, advise us on how we undertake our research, and help us understand what the findings mean for young people with lived mental health experiences. We're still recruiting for this group, so please email wolfsonyoungpeople@cardiff.ac.uk, just here if you're interested in taking part. And that email address will remain at the bottom of the slides as we go through the presentation. So to summarise then, I've spoken about the need to liaise with policymakers from the outset in order to conduct research which is able to inform and evaluate policy. I've highlighted how the Wolfson Centre is well placed to conduct research that can rapidly translate research to policy change with our multidisciplinary expertise, resources such as the Schools Health Research Network, the SAIL Data Bank, an adolescent data platform, our linked research post with Welsh Government, and our advisory groups and boards who help to guide our research. And all of this is, of course, particularly important in the context of the current pandemic and the many changes young people have experienced over the last 18 months. That brings us to the end of the presentation. Thank you very much for listening, and I'm happy to take any questions.
Thank you very much for that, Chris. I think judging from the Mentimeter contributions we had from the audience, hopefully that kind of gave everybody a really good overview of where we're at with the Wolfson Centre at the moment. And as Chris said, if anyone's got any questions, please do pop them in the Q&A box. So we've had a question, Chris, from Siobhan.
Oh, sorry.
What plans do you have to include third sector organisations in your research? There's a wealth of information and engagement with young people that could easily be missed without this.
Yeah, that's a great question, and thanks for asking that. So, yes, that is very important to include third sector organisations in the design and implementation of research. So part of my role will be not only liaising with young people themselves and Welsh Government, it'll also be looking to liaise with mental health charities to consider their priorities, their key questions moving forward, because of course they have lived experience and expertise in these areas. So that's definitely something we'll be looking to move forward. And there's numerous mental health charities in Wales that could help us with that, like Man Cymru and MQ as well. So that's definitely something we'll be doing.
Great, thank you. Any other questions? Oh, question from Emma, Chris. Similar to Siobhan's questions, will the data be gathered from SGYRN be accessible by third sector organisations?
Thank you very much for your question. So I'm not directly involved with SGYRN, so I won't be able to provide a definitive answer to this. I don't think so. I mean, any findings from SGYRN studies obviously will be shared, as I mentioned, in a general sense in publications and social media, but in terms of the data itself, I don't think that would, in terms of raw data, be accessible. I think bodies, if they want to use any data gathered on platforms like that, have to apply and go through an approval process, but certainly findings from studies relating to our work will be disseminated in publications and on social media and other channels like that, if that answers your question.
Okay, thanks, Chris. And another here from Nikki. She said, can you give an idea of what rapid response looks like to you in terms of a whole school approach? What if young people can't attend?
So a rapid response in terms of a policy change. Yeah, that's an interesting question. Obviously, especially in the current circumstances, you know, some young people are still shielding and aren't able to go to school. That's something that's really interesting to consider actually moving forward, because of course, in surveys of school mental health, they'll be done based on school experiences. So if the young person can't attend school, obviously that's individuals there who are being left out. In terms of a rapid policy change, I'm not sure what that would look like actually. for that particular population? That's a really interesting question and something I think we'll have to consider moving forward. But I do think it's important to include, for us to consider, groups such as young people who can't attend school, and obviously young people who have mental health conditions who come from other populations, like those with neurodevelopmental syndromes. And I think by us liaising with young people, with charities, with our advisory boards and our youth advisory groups, we'll be able to hopefully cover all of those different groups so that we don't miss anything like that. But in terms of a rapid response, yeah, I'm not quite sure, actually. I think that's a really good point and something we need to consider.
Okay, thank you. And another question from Siobhan. Chris, what age range will the research look at?
Yeah, so Wolfson looks at young people, and I believe that's broadly defined as 10 to 25, up to the age of 25. I think there's some capacity to look at younger children as well, but within all the various different studies, the age ranges will be slightly different. So some will perhaps look just at adolescents, some at younger children, but overall I believe it's 10 to 25. So, you know, we're covering key periods of adolescence where young people are particularly vulnerable to emotional difficulties and to developing mental health conditions, and also as they move forward into young adulthood and up to around 25, so that we track key changes in participants' life. And I think that's particularly important in the context of children in clinical services who transition from child and adolescent mental health services to adult mental health services, to continue to track individuals as they move into those services rather than just being lost. So we're aiming, that's the broad age range that we're looking at.
I will now introduce our next speaker, who is Dr. Vicky Powell. And Vicky is a postdoc researcher from the Wolfson Centre, and her research focuses on understanding the risk and protective factors for young people's mental health. Vicky completed her PhD at Cardiff University, and that focused on the relationship between the contributors for ADHD and depression. So Vicky, I'll hand over to you.
Hey, thanks, Bex. I'll just put my slides up and share them with you. There we go. Hopefully everyone can see those. Okay, so today, well, I'm talking about something a little bit different from Chris now. I thought I'd talk about some work I did for my PhD, as Bex just mentioned. So, but I'm currently working as a postdoc at the Wolfson Centre. I'm happy to answer questions about what I'm doing at the moment as well, which is focusing more specifically on depression. But my aim for my PhD was to look at the link between ADHD and depression and kind of different factors that explain this relationship. To give you some broad background to my PhD, so ADHD, or attention deficit hyperactivity disorder, is a neurodevelopmental disorder, so typically onsetting in childhood, and it's characterized by three main domains of symptoms. So those are inattention, hyperactivity, and impulsivity. So inattention is like the inability to concentrate and focus on tasks, or having difficulty in that area. Hyperactivity refers to kind of difficulty with sitting still, or not kind of running about and walking about when it's kind of inappropriate to do so. And impulsivity refers to difficulty with kind of thinking things through before you act. So ADHD is associated with an increased risk of depression, and we see this in samples both in the clinic and in the general population. But the reasons behind this are not very clear. However, it's important that we look at different reasons that might kind of come in between the path from ADHD to later depression in order to inform how a clinician or how school counsellors, for example, might intervene and prevent depression occurring in children with ADHD. So in my PhD, I focused on a few different potential explanations. So I looked at shared kind of environmental or social risks, so things kind of happening in the child's life that might kind of explain this link. And I also looked at genetic risk, which I'll touch on a bit more briefly at the end, in addition to looking at how ADHD might affect the presentation of depression. So does depression look different when you have ADHD? But today I am going to focus more on these kind of environmental and social risks. So for my PhD, I was really interested in school and friendships as kind of potential risks in the child's life or environment. The reason for this was that friendship and academic difficulties are both associated with ADHD and with depression in separate studies. So one proposed route from ADHD to depression may be via difficulties in these domains. However, there aren't many studies that test this kind of relationship, particularly looking at the relationship over the course of development. So including kind of young childhood into adolescence and kind of early adulthood. So my research question for my first piece of work in my PhD was, do these difficulties with friendships and academic performance contribute to or mediate the link between ADHD and depression? So what I'm talking about when I say mediate is, are these difficulties acting as a middleman, if you like? So is a child with ADHD more likely to experience difficulties with these domains, and then therefore does this increase their risk of later depression? And all of this work is published in the European Child and Adolescent Psychiatry Journal. I've included the citation at the bottom if you want to read more. So how I tested this was I used some participants from the Ausbach cohort. So about 2,000 participants from a longitudinal population-based cohort. So essentially in the region of Bristol, kind of wider region around Bristol, thousands of children have been followed since birth, kind of with repeated sort of interviews and questionnaires. So this was the cohort I used to test my research question. I used ADHD symptoms at age 7, which were reported by the parent, self-report peer problems, and also the GCSE results of the child, both at age 16. And then I looked at reported depressive symptoms at age 17. And I've kind of shown how I tested what the model was that I wanted to test at the bottom there. I used linear regressions to test the direct relationship between ADHD and depression. And then I used something called mediation analysis to test the indirect kind of pathway that I've highlighted in grey. So what I found was that ADHD symptoms are associated with adolescent depressive symptoms 10 years later. So as you can see on the graph, as the ADHD symptoms at 7.5 years increased, the children's depressive symptom score 10 years later also increased. And when it came to testing the mediated pathway I was talking about, friendship difficulties and academic difficulties both contributed to part of the relationship between childhood ADHD symptoms and later depressive symptoms. And when I kind of looked at what the relative contribution of each was, friendship seemed to explain about 15% of the link between ADHD and depression, and academic difficulties about 20%. So to give you a conclusion on this first bit of work, these findings support the existence of pathways from ADHD to depression across development via difficulties with friendships and also with academic performance. And this highlights these difficulties as potential targets for preventing depression or intervening in those with ADHD. One of the limitations of this piece of work was that I used a kind of general measure of peer relationship problems. So it was a small questionnaire measure that actually had a lot of different kind of peer relationship problems within it. So it's kind of hard to see what actually is important within that broad measure. So for my next piece of work, I really wanted to focus in on friendships and have a look at what different aspects of friendships might be important in the link between ADHD and depression. So that brings me on to my next piece of work. To give you a bit of background again here, findings in small samples suggest that those with ADHD diagnoses have fewer stable friendships, but we don't know very much about the different features of friendships in those with ADHD, how they're impacted on and how they then impact on later depression symptoms. Friendships can be thought as having 3 dimensions. Presence, so does the child have friends? How many do they have? And how stable are they over time? Quality of friends, so are these friends, are they good friendships? Are they supportive? Do you feel secure in the friendship? and characteristics of friends. So what kind of person are you friends with? Are they kind of more cooperative type, disruptive, hyperactive, etc. So my research question for this piece of work was, which aspects of friendship are more important in the link between ADHD and depression? So I did a kind of similar model to the last time. I was looking at whether these different features of friendship kind of acted as a middleman in the link between ADHD and depression. I also additionally tested whether the relationship of the child with their parent played a role in this. So whether it might affect how friendships kind of affect this link. I'll touch upon that in a bit more detail as I go on. So to test this, I used a sample called STARS, and about 1,700 pupils participated and had the data that I wanted to look at. And this is another longitudinal sample, but based in several schools around Greater London. I used 2 waves of data that were conducted 7 months apart, one at the beginning of year 7 and one at the end of year 7. That's the first year of secondary school in the UK. And again, I used very similar analysis techniques to kind of test my research questions. How these were measured were mainly questionnaire measures, including a questionnaire measure on parent-child relationship. So the children were asked to name 3 best friends and to report on how stable they were over time, whether they were still friends with them by the end of the year, for example. They were also asked to report on how satisfied they were with these relationships and the quality of these friendships. And they were asked to report on the kind of characteristics of peers in their classroom. And I used this data to kind of look at the characteristics of everybody's friends. So what I found was that ADHD was associated with depression, like the last time. And when I tested what mediated this kind of effect, while the presence and characteristics of friends did not seem to mediate the relationship between ADHD and depression, quality of friendships did seem to be important, accounting for about 9% of this association. So it really seemed to be the quality of the friendship, how supportive they were and how secure the child felt in that friendship, that was important in the link between ADHD and depression over that 7-month time period at school. And I had a quick look at parent-child relationship quality as well, as I mentioned earlier. And I found some evidence to suggest that this mediated effect via friendship quality was smaller, or kind of less prominent, when the young person reported having a warmer relationship with their mum. So what this might suggest is that having a warm relationship with your mum can compensate somewhat for having poor friendship quality. And this might be helpful in kind of preventing depression in these children with ADHD. To conclude, friendship quality in the context of family relationships seem to be important to consider clinically in those with ADHD for reducing depression risk. And the findings suggested that interventions that improve the parent-child relationship and also friendships may have promise in preventing these depressive outcomes in those with ADHD. Obviously, there's limitations with every study, and one of the limitations of this study was the short follow-up, as it was 7 months kind of compared to 10 years in the study before. Again, if you want to read more about this study, it is published as well. I've got the citation at the bottom there. Just to kind of give you a quick overview of other findings from my PhD, so it's a bit of a whistle-stop tour. I also looked at genetics. I found a series of kind of areas of the genome, or kind of individuals' genetics, that seem to have a contribution jointly to both ADHD and depression. And these areas of the genome were associated to a smaller extent with academic attainment and other mental health disorders such as anxiety. I also looked at the effect of ADHD symptoms on the clinical presentation of depression, and this was done in a sample of adults who are currently depressed. And I found that ADHD symptoms were associated with a more severe, chronic and earlier onset depression in this group. ADHD was also associated with other outcomes such as increased risk of self-harm, hospitalization, and taking a non-first-line antidepressant. So really seemed to be indexing a kind of more severe form of depression. And both of these are either in press or published. So if you want to read more, you can. I've had a lot of help through my PhD from lots of lovely people in the wider team, and I've also got my funding there. So with that, I'll thank you for listening, and I welcome many questions.
Great, thanks, Vicky. We've got a question here from Nikki. Oh, a few questions from Nikki. There's quite a few actually, Vicky. So she's given how underdiagnosed ADHD is generally accepted to be in girls, do you think there is a link between undiagnosed ADHD in girls and an increase in attempted suicide rates in young women?
Yeah, I think that's likely. I haven't tested that myself. I certainly did notice in my work that the relationship always seems to be slightly, but not significantly stronger in girls between ADHD and depression. And obviously we know that girls are more likely to have a missed diagnosis of ADHD. And, this is likely to lead to delayed treatment, which of course is likely to kind of lead to worse outcomes for that group. So that's a really interesting question and a really important one. There's certainly some very interesting research in that area about kind of girls kind of showing higher genetic risk for kind of ADHD if they've been diagnosed with kind of depression and anxiety versus boys. So perhaps being diagnosed with the sort of wrong thing at the wrong time. So yeah, it's a really interesting point. Sorry, I kind of waffled there. If that was a helpful answer.
Thank you. Another question from Nikki. How do we improve teacher-parent understanding of ADHD symptoms in girls specifically?
Yeah, that's a very tricky question. And again, is something I noticed in my work, that the relationship between ADHD and depression in my second study I was talking about, I didn't actually mention this, the ADHD was rated by the teacher instead of the parent that time. And the association was a bit weaker than we might have expected. And I think that might be because the teachers were underrating slightly compared to perhaps what the parent might have rated. And certainly I can imagine in girls, this might be a particular issue. I've read papers that kind of suggest that teachers are more likely perhaps to rate people as having ADHD symptoms if they're more of the hyperactive subtype of ADHD rather than the inattentive. And of course, there is some evidence to suggest that boys are more likely to have the kind of more hyperactive presentation compared to girls, who are more likely to have inattentive. In terms of improving that, I guess from a research perspective, kind of research that really tries to focus in on those research questions and draw attention to perhaps, missed cases of girls with ADHD, may help inform policy, like kind of what Chris was talking about earlier, and hopefully have an impact in schools, for example. Yeah.
And there's been a couple of questions, Vicky, relating to meaningful friendships.
Yeah.
So from Nikki, how can we support meaningful friendships in school, outside school, as an insulating effect for depression? From Emma, what interventions would you propose to target friendships in a meaningful way?
Yes.
Go ahead.
Sorry, Vex.
No, go ahead. That's okay.
So I can probably answer those two in kind of a melded answer. There are some interventions that are kind of being trialed at the moment that I know of. There's one called PEERS, I believe, is the acronym. And they found some kind of preliminary evidence that their intervention might be helpful in children in a very small sample of children with ADHD. And it's a friendship building program with a parental component, which kind of sort of fits into my findings in the last study there. That, in addition to kind of trying to encourage a child to build better friendships, involving the parent might make the intervention much more effective. There have kind of been previous interventions trying to focus on the child's social skills, and there's really very little evidence that the effects of those interventions are very long lasting for the child. So I think by focusing kind of more on friendship building and involving the parent in that might be a kind of it's kind of early days in that research, I think, but it looks like it might be more promising. So this study found that by using this intervention, the children had initiated more friendships. They'd hosted more get-togethers with the help of their parent, you know, with children from school. And they also seemed to show a bit more awareness of like social kind of skills in a sort of test they completed at the end. Yes, that's the peers intervention, if you're interested. But that's just one example, I guess. There's plenty of interventions out there that have been developed or are being kind of worked on.
Thanks, Vicky. Another question on friendships again. If a child has a poor friendship quality, consequently has a high school non-attendance rate, does this lead to poor academic achievement and then depression? Your thoughts?
Yeah. Oh, yeah, that's such an interesting point. And definitely when I was writing my thesis up, and I had to consider all these kind of different complex interactions that could be happening between the different things I was measuring. And yeah, that could well be a kind of potential explanation of results I've seen. Certainly, I didn't measure school dropout at any point, but that would be quite interesting to look at as well. But yes, they both seem to be contributing kind of independently, academic attainment, I mean, and friendship problems. But yeah, it's completely conceivable that one is affecting the other in a kind of more complex pathway.
Thank you. And one final question from Siobhan, Vicky. She said, really interesting, thank you. And are there any plans to link to some of the Welsh ACEs research, considering that trauma can impact on development, biology, and exploring other neurodiverse categories?
So that's so interesting, and thank you for your question. I've not worked in that area myself yet, but it is something I find really interesting. I think the literature in that area is really, really interesting. And I have thought about it myself before, kind of how that could be linked in. It's not something I've done yet, but yeah, definitely something to consider kind of for future work. Yeah, thank you.
Okay, that's great. Thank you everyone for your questions on that. And thank you, Vicky, for such an interesting talk. So I will now introduce our final speaker of the evening, Dr. Yulia Shenderovich, who is a senior lecturer at the Wolfson Centre. She joined Cardiff University a few months ago, having previously been at Oxford and Cambridge. And Yulia's research interests focus on services for young people's health and how we can develop and evaluate those services to find out what works well in practice and on a large scale. Yulia, I'll hand over to you.
Thank you so much, Bex, and it's great to be here with everyone today in this shared virtual space. So I think my presentation actually is going to build on what we've just started discussing about the importance of relationships and Siobhan's question about adverse childhood experiences and their impact. I'll talk about violence prevention, preventing violence against children, and how that is one of the ways of protecting and improving young people's mental health. Other areas that I will be working on at Wolfson Centre will be focusing on school-based interventions, the School Health Research Network that we heard about from Chris, and also together with Dr. Lucy Riglin, promoting open science and supporting learning about quantitative methods and quantitative inference across the Wolfson Centre work streams. But today I'd like to tell you more about violence prevention, and we'll start with the definition first in the best academic traditions by asking you what, in your opinion, violence is, how you would define that. There is a Mentimeter code there, same as in Beck's slide. If you can go to menti.com and enter this code here, I hope that works. Then please go ahead and if things come to mind, pop them into the chat or the Q&A. Oh, there you go. Causing harm. And that's really helpful. And glad the code is working. Yeah, so you will see in the definition that's widely used, which is definition introduced by the World Health Organization, who have been doing a lot of work in this area. It is all about causing harm or high likelihood of causing psychological or other harm, physical harm, maldevelopment, deprivation to someone, an individual, a group, or even yourself by using force or power. And specifically when it comes to violence against children, we know from several decades of research that depending on child's age and other factors, different forms of violence may be experienced across childhood. So for instance, for younger children, violence in the home is much more common, whereas as children get older, start interacting with peers, issues like bullying, youth violence, intimate partner violence become more important as well. A lot of my own work and what I'll talk about today has focused on child maltreatment and particularly the role of family and caregivers in preventing that. So the reason we're talking about violence today, as we've already mentioned, it is an important risk factor for mental health, lots of negative mental health outcomes across the life course, including anxiety and depression, which are the focus of work at Wolfson, but also both directly through mental health and risk-taking and indirectly through mental health and risk-taking and directly through injury. Violence against children can affect physical health, including non-communicable diseases such as cancer and diabetes, and really even impact somebody's health and life expectancy. So it can have really fundamental impacts, but it's also a violation of human rights. So the UN Convention on the Rights of the Child, which is actually now the most widely ratified human rights treaty in human history, protects the rights of the child against violence. And we also know that violence against children is very common. So depending on the definition you use, of course, the numbers vary, but using a fairly wide definition, if we look at past year exposure, actually nearly half of the world's children, 1 billion children, have been exposed to some type of violence based on modeling studies. And then if we look at more severe types of violence, homicide being the most severe one, we also see that numbers are quite substantial. So almost 100,000 children in 2012, which is the latest estimate that I'm aware of. So we know it's a massive issue, and we also know that it affects countries and population groups disproportionately. So first of all, 90% of the world's children live in low and middle income countries. So a lot of the world's children are there. And also some low and middle income countries, like South Africa, for example, where a lot of my work has been based, also experience disproportionately high burden of violence against the children and also violence in general. And Bex has very kindly posted the code for this next question, which is about what, in your opinion, can help prevent or reduce violence against children. So any ideas on policies and programs that you think can be helpful in preventing or reducing violence against children are welcome here. And I'll just give you a moment to enter the code, which is 19232036. So we've got reducing alcohol use, drug use, poverty, early years parenting support, yeah, all great ideas and backed up by a lot of evidence. The framework I'll briefly introduce next, and thank you very much for this additions, addressing poverty, is called INSPIRE. And that's seven pillars that have been developed based on evidence we have about programs and policies found in research studies as effective in reducing violence against children. And you'll see it touches on a lot of themes that you have come up with. But first, I'll just briefly talk about the public health approach to violence prevention. I think it's been in the news a lot, so many of you may be already familiar with it. And it's really about approaching violence as a public health problem. So we first define it. We talk about what violence is, as we have started doing today, and how common it is, different types of violence, and how it affects different population groups. We identify risk and protective factors. And then based on that, based on our understanding of mechanisms of how and why violence happens, we develop and evaluate interventions to prevent it. We then scale up the interventions that work well. We look at how they work at a large scale, which sometimes can be different from small pilots. And then we continue looking at how services are working in practice as they're being delivered. And the cycle goes on as, hopefully with our policies, we also modify some of the problems we are addressing. For instance, the rates of violence and responses to violence. There is quite a lot of research on risk factors for violence against children. And like any issue, of course, we can look at it in different levels. So in this model, which is often called the Socioecological Model, here we start with thinking about the individual characteristics. For instance, we know that boys and girls have different risks for different types of violence. We also look at relationships. So we've talked about peers. We also talked about parents. We also look at community factors. So we already mentioned poverty as one of them, institutions and services and others, and then wider societal factors. So social norms, which also are very important for violence and violence prevention. Spanking children is one example of social norms and norm change that we have seen in many countries over the past several decades. So the INSPIRE framework I mentioned builds on all of this. And the 7 pillars it identifies as effective if implemented well, in preventing violence against children is implementation and enforcement of laws. So for instance, banning corporal punishment of children at home and in school is one example. The promotion of norms and values that don't support violence. Safe environments, so this can be things like creating physical safe spaces, for instance, good lighting in the evening around areas where children play and spend time. Parent and caregiver support, I'll tell you a little bit more about that in a moment, but we already heard in an earlier Mentimeter exercise from somebody about early childhood support. So that type of program which strengthens the families and the caregivers' ability to support the children in their care. Income and economic strengthening, addressing poverty. So programs like social grants, cash transfers have quite a lot of evidence in preventing many types of violence, including violence against children. So trying to remove some of the stresses and burdens. And response and support services, which is addressing violence once it has occurred, supporting survivors of violence, and educational life skills, which is about things like social and emotional learning and helping young people advocate for themselves and build strong relationships to reduce their chances of being exposed to violence. So parenting programs is one of the intervention strategies identified in the INSPIRE guideline, and it is one that I have been working on. So the motivation for that, as we discussed, is that parents, relationship with parents is a really key one for protecting children against violence. And we also know that violence can occur at home, for instance, in the context of corporal punishment. Of course, we know that vast majority of caregivers are doing all they can to support children. So parenting programs really are a space for parents to get together, usually in a group of 10, 15, 20 parents, depending on the parenting program, together with a facilitator, and have a space to discuss issues, learn new skills by practicing them and discussing them. And depending on the age of the children that the caregivers have, the topics of parenting programs will vary. So for young children, it will often be about cognitive stimulation, learning about developmentally appropriate expectations, meaning knowing what you can expect the child to be able to do or understand at a given age. And then as children get older, for instance, when they reach adolescence, one of the key age groups for the work of the Wolfson Centre, it's looking at risk-taking and interactions in the community that adolescents have and caregivers' role in supporting them. So final question is, now that you've heard about parenting programs and what they mean, is whether you have any experience with parenting programs for parents and caregivers, either as a participant, as a young person, or as a caregiver, or as a facilitator perhaps, or as a researcher. in any capacity. Yes, we have somebody who has experience. So that's great. You may already know a lot of this, and questions are welcome. Thanks for filling it in. We have somebody who's new to this. So hopefully you may be a little bit more interested now in this type of program, if that's relevant to you or people in your life. Another person with some experience, that's really interesting. Great. So as those of you that have heard about parenting programs may already know, there is quite a substantial evidence base for this type of programs, including from randomized trial, which is a design. I think many of us have now heard, for instance, with the COVID vaccines and previously with other types of medical studies, that's also used for evaluating social interventions, when we randomly, sort of by a flip of a coin, allocate people into 2 groups or more to receive and not receive an intervention, and look at the difference between the groups. So then once we have a number of randomized trials, we can actually do a systematic review, looking at all the studies that have examined this question and pull them together to see what we've learned across the evidence base from individual studies. And from that evidence-based parenting programs, we know that on average, they are effective in reducing child behavior problems, reducing child maltreatment by caregivers, and reducing caregiver depression, among other outcomes. Most of this evidence historically has been from Europe, including many studies conducted in the UK, North America, Australia, but increasingly we're also seeing more studies from other parts of the world, which also suggest that these programs are transferable and can work well in different contexts. There is, of course, also, like in any research area, a lot we're still learning. So one of them is what happens after an evaluation of an intervention. So we found out something works. Let's say we have a new program, we've tested it, but how is it actually implemented in practice after the evaluation? What happens in 1, 2, 3 years, both with the quality of delivery, but also with caregivers and families that have taken part in the program? So how long-lasting the effects of parenting programs are is one of the areas where research is still ongoing. We are also still learning about how intervention delivery and adaptation may vary between different contexts across societies and within societies, and how to disentangle effects caused of different parts of parenting programs, which are often lasting a couple of months and can be relatively costly to deliver. So there is many more areas that are still being explored, but this is a taster. And to give you one example of how we are addressing these questions, over the past year and a half, we've been talking to several providers in Cape Town in South Africa about how they have continued to deliver interventions for young children and adolescents and their caregivers in the context of COVID, and adapting to that, following an evaluation suggesting that the programs were effective. So with this, I'll thank you very much for your time. There is my email here if you have any questions, and also any questions we might be able to answer in the next few minutes are most welcome.
Thank you, Yulia. That was really, really interesting. Have we got any questions from the audience? Give everyone a few moments just to think on it. Okay, so a question here, Yulia. Is there any research that looks at the impact of the content taught on parenting programs versus the experience of the program, e.g. the value of peer support, how people felt connecting with other parents, etc.?
Ivan, this is a superb question. And I don't think I am aware of a lot of research like this. I think there is a few programs that have done a little bit of what we call attention control, where they have offered, for instance, in the context of a randomized trial, parents allocated to not receive the intervention, so the control group, to receive one information session, for example. But that's quite different because that doesn't really create that peer support and these relationships. So I think it's definitely a really important area. And as I mentioned, we don't really know yet how these different components and parts of the program work and which ones of them are really important. One of the things that has been happening a lot, particularly in the context of delivering programs in lower resource settings, has been program delivery by what are often called lay or community facilitators. So facilitators who don't have psychology or medical degrees, but are members of community that have had, let's say, a week of training and maybe did the programs themselves as caregivers. So I think that's a really important area for ongoing research. And certainly when we talk to parents and children, because often children, especially adolescents, also take part in the programs, they talk both about things they've learned from the program, like different tools. So for instance, planning a household routine, but they also talk about relationships that they've built. So I think both of these seem to be really important. And it's one of the areas to explore to see if, for instance, we can make the programs easier to deliver and more accessible by focusing more on relationships and maybe removing some of the content. That's an ongoing area of work that some of my colleagues, for instance, are currently working on factorial trials where you have many different groups and sort of try to isolate the impact of different intervention parts.
Great, thank you, Yulia. Another question from Nikki. Do you think there's scope to develop these parenting supports through schools?
Yes, again, an excellent question. I think the answer is certainly yes. I don't think there are many examples of this, but there are some. So for instance, we are currently involved in research in Tanzania, where a parenting program was delivered by teachers and using the existing infrastructure of schools and relationships with caregivers. That had some positive feedback, but certainly needs more rigorous evaluation. There are also examples I'm aware of in the UK. For instance, a PPP program was recently delivered by early childhood setting workers. So I think there is lots of scope. I don't think this has been a very common format of delivering these programs, perhaps for practical reasons and existing burden on school and educational establishment staff. But it's definitely an important area that I think is very promising, particularly, again, in terms of accessibility and scale up.
Great, thank you. And another question from Siobhan. Do you know if levels of violence towards children have gone up or down over recent years?
Yes, excellent questions.
Sorry, Yulia, and are there any reasons why it may have gone up or down?
Yes, as always, the researcher answer is it depends, and depends where you look, which setting. And of course, as often is a challenge with longitudinal research, when we try to look over decades, is that things haven't necessarily been measured in the same way or measured well a long time ago. So often when we observe changes, we are not sure what to attribute them to, if it's genuine change or change in measurement. In the UK, there is some really excellent work by Dr. Michelle Degli-Esposti that has actually pulled together rates of violence, and in particular violence against children, over several decades, finding that they have generally been coming down in the UK. But I don't think there is comparable data available in most parts of the world. And certainly things may be different looking within a few years and at a specific type of violence versus these longer term trends. So in terms of the reasons, specifically as far as I'm aware for this research in the UK, and also in the US, where something similar has been found, there is a number of potential reasons that have been suggested. They include increasing standards of living on average. And they also include changing societal norms. So for instance, we already mentioned spanking. Norms have also been changing around gender-based violence in many societies. And also there is lots of other hypotheses. Some may be very unexpected, like removing lead from fuel, because lead has been linked to aggression, or increased access to psychiatric medication. So all kinds of hypotheses are out there. We don't really know for sure, but we certainly do know that factors like poverty and societal norms are important. So I think if we do affect them, we are likely to have at least some some influence on population level trends as well. But again, it's an ongoing research area.
Great, thank you, Yulia, and thank you everyone for your questions throughout this evening. That's fantastic. Right, so we are nearly at the end. My video back on. So I've got one more question to put to our audience before we finish this evening using Mentimeter. So the link and code are now in the chat, along with all of the contact details that we've shared throughout the evening of the Wolfson Centre. So I will just share my screen for the final time. So the final question to you all today is, what is the main thing you will take away from today's webinar? Useful resources, new knowledge, a better understanding of a complex topic, or inspiration to learn more? So we've already had some answers there. Sense of where the research is heading, updates on current research. Just leave it a few moments if anybody else wants to add their thoughts. Oh, thanks, Chris. I can see Chris has added a link in the chat about Shern, and we'll be sure to share that link and any other resources that have been mentioned in the webinar this evening in our follow-up emails to you all. Great. Okay, thank you very much, everybody. So there we go. Thank you for joining us this evening. A special thanks to all of our speakers for their really interesting talks. We hope you've enjoyed it, and the best way to keep up to date with everything that's happening at the Wolfson Centre is to head over to our website, cardiff.ac.uk, and to follow us on social media, which is @Wolfson Centre. Thanks once again for joining us, and hopefully see you all again soon. Thank you very much. Take care.